we're going to have Q&A for this amazing group of speakers that we've had since lunch. There's a microphone over here. There's a microphone over there. Some people have submitted questions through the app. Just a couple things. There can't be personal diagnosis and medical advice given. So please keep that in mind. And generally, questions have a form ending with a question mark. So if we could do that so that people get a chance to answer their questions. And, we're just wanting everybody to have a chance to interact that can hear. So I have a really hard time seeing. I'm just going to start over here. If you could just introduce yourself and then ask the question, please.
Thank you. Alan Schaefer, pulmonary critical care, sleep, obesity, metabolic health, Albany, New York. My question is about the thyroid. I see a lot of patients that are on amiodarone, beta blockers, and I know that they can block the conversion of T3 to T4. And I've seen a lot of people that are profoundly hypothyroid. How do you manage those patients? And also in terms of, do you have a protocol in terms of how to adjust the T3, T4 doses, or you just sort of play it by ear and adjust based on symptoms and numbers?
Thank you for asking. So I am not a doctor, so I can't prescribe anyone medication, but if somebody's taking a drug that impairs that conversion, then I would want them to take T3. You can just give them T3 without any T4 and go by the symptoms. You can monitor the labs every few months, but what's really going to tell you if they're at the right dose is the resolution of symptoms.
Right, and a lot of them on the amiodarone are on it for AFib, so that's always something to watch for too. That's why medicine is so much fun.
Well, so yeah, that's a little tougher. I not sure what to say in that case, except that, well, Tro, you had your...
Yeah, so for the amiodarone, a lot of times, so if they have concurrent hypothyroidism, you can just add, a lot of endocrinologists now are favoring, adding T3, and in a situation like that, I don't think it would be, completely out of the ordinary. So it used to be that T3 was like never done. I mean, Amy talked to me maybe 7 years ago and said, "Hey, are you doing T3?" And I'm like, "No, not really." She's like, "Maybe you should consider it." And in those 7 years, let's just say, now it's become a lot more favored to add T3 based on clinical symptoms. Okay. There's no protocol, particularly for amiodarone. Yeah. But amiodarone is a terrible drug.
It is. It just shuts the thyroid right down. And a huge reverse T3. Thank you.
Over here.
Hi, I'm Crystal Starnes. I am a family nurse practitioner here in Colorado, in Denver. I have maybe a two-part question, unless it goes lengthy, for Dr. Johnson. So I want to know your thoughts on what truly comes first. We know that insulin resistance affects sodium retention in the kidneys. So people with insulin resistant who become obese, theoretically, may have higher serum osmolality because they have more sodium retention in the kidneys, high blood pressure, things like that. Or is it the increased salt intake that induces the obesity? Because it seems like you're saying the former, but...
Thank you for bringing this up. So it turns out that if you give fructose to a human, even like 50 grams or 30 grams, blood pressure goes up acutely, and you activate this pathway. And if you give high salt diet to a person, after 4 or 5 days, you can actually induce insulin resistance in humans. So it's been reported. So they're both kind of independently can induce insulin resistance, fructose and high salt, and they work similarly, but then in insulin resistance, also, when insulin levels go up, they increase sodium reabsorption in the kidney. And also fructose induces changes in the kidney that make you want to hold on to sodium as well. So fructose will also stimulate sodium reabsorption. And so it's a big cycle. It's basically like a vicious cycle. And I'd be happy, I have written some papers on this pathway, so I'd be happy to send it to you. But basically, insulin resistance stimulates sodium retention, but sodium and sugar stimulate insulin resistance. So there's a big circle.
Okay, thank you. And then one more. So also in insulin resistance, you can have suppression of the nitric oxide, and nitric oxide can be implicated in vasopressin regulation, if I'm correct, if I'm thinking correctly. So again, which came first, the chicken or the egg?
Did you?
So if you were talking about the high vasopressin levels, but in insulin resistance, you can have inhibition of nitric oxide, which I believe can affect vasopressin regulation.
Yeah, so inhibition of nitric oxide or endothelial nitric oxide is part of this whole pathway too. Mm-hmm. So fructose and uric acid inhibit endothelial nitric oxide levels, and that also helps raise blood pressure because it causes vasoconstriction. Yeah, it's a pretty complicated pathway, to be honest. But
it's hard to tell, like, is insulin resistance causing this, or is it some other thing, like fructose metabolism?
It's all part of this fructose pathway. Actually, if you put fructose on an endothelial cell, you can inhibit nitric oxide. And uric acid does the same. And so it's really all part of one system. You know, I'd be happy to send you references and stuff.
That's fine. Thank you.
Yep, you bet.
From the app, here's the question I'll just ask everyone on the panel. Who should not do a low-carb, high-fat, it's written LCHF, so I'm interpreting, diet. Who should and should not intermittent fast?
Who should not be on a low-carb diet?
Exactly, that's the question. Are there people that shouldn't be offered this diet? And are there
Well, there was this long-standing hypothesis based upon early data that, if you have kidney disease, you don't want to be on a high-protein diet because a high-protein diet can accelerate kidney progression. And so as a nephrologist, I was taught this during my fellowship, and for sure, if I take an animal with kidney disease and I put it on a high-protein diet, it will progress. It's a fabulous method to accelerate kidney disease. Having said that, what they've shown is that most patients with kidney disease go on ACE inhibitors and angiotensin receptor blockers and SGLT2 inhibitors. And actually, if you put an animal on those, then a high-protein diet doesn't cause anywhere near like the problem. So the issue of a low-carb diet, a lot of people were really worried to give a low-carb diet to kidney patients because it often translated into a high-protein diet and could cause progression. But now we recognize that high-protein diets are not necessarily bad on these therapies, and there are now papers coming out saying that the low-carb diet can be good in chronic kidney disease.
And of course, there's some question about whether necessarily a low-carb diet is a high-protein diet. And of course, we're talking about undefined terms here, but okay, thank you very much. If we could just pass the mic down and...
So I would say that patients who are deprivation sensitive are not going to do well with intermittent fasting. They're not going to do well with a really strict, ketosis. And so you want to be careful, with those patients. If they're prone to hypoglycemia. I've had patients too where they just don't feel good on keto, and so we can moderate their carbs and they may feel better, but there are some patients who just don't feel well, and I think go by symptoms, right? If patients and work with them that way, I think is important.
Thank you.
Absolute contraindications would be active pancreatitis and hypoglycemic shock.
Thank you.
For intermittent fasting, somebody who's severely underweight, they have no business fasting, and so a cancer patient, somebody with severe anorexia nervosa, they need to be eating regularly to try to reestablish a normal weight.
Thank you.
I think there are some very rare genetic errors of metabolism involving fatty acid pathways that maybe that would, medically contraindicate a low-carb, higher-fat diet. But intermittent fasting, I'm primarily a writer, and words matter to me. And if we don't define it, are we eating 1 meal a day, 2 meals a day? Are we eating only 3 days a week? Are we fasting for entire days here and there? Depending on how we define intermittent fasting, it can be fine or it can be terrible. I think some people get into trouble, and we maybe, I hate the word blame, we maybe have some responsibility in that. We've emphasized fasting so much, we've actually made people terrified to eat. But beyond that, I mean, with the book that I wrote on Alzheimer's, anyone who is elderly or frail or, like you said, underweight, I don't recommend any kind of fasting.
Thank you. Question over here.
Hi, my name is Kelly Miller. This question is for Dr. Palmer. I specialize in nutrition for people in recovery from substance abuse. I've had a lot of success with a lower carb diet, but we've typically avoided keto because of the restrictive aspect and the rigid thinking that comes along with addiction. I'm curious, in your client population, your patient population, have you specifically seen a reduction in cravings for drugs and alcohol with the folks that are on keto?
So yeah, Nora Volkow led a study at NIAAA, randomized controlled trial of people with alcohol use disorder admitted to a detox unit at the NIAAA. Half of them got ketogenic diet, half of them got standard American diet. The ones assigned on the ketogenic diet had lower need for benzodiazepines as part of their detox. Despite getting fewer benzodiazepines, they had fewer withdrawal symptoms overall. They reported lower cravings for alcohol. They had reduced brain inflammation on brain scan, and they had improved brain metabolism also on brain scan. More studies are ongoing in that population. I was actually pursuing a study of the ketogenic diet for opioid use disorder right before the pandemic hit. And we were only able to run 2 subjects, and then the whole thing got shut down because of the pandemic. But one of the subjects literally came in almost skipping and singing, saying, "I have never felt this good in my whole life. Thank you so much. You have changed my life." Avoided all opioids for 3 months at that point. He had never gone that long in prior detoxes. His girlfriend thought he was a changed man. I don't know what the long-term outcome of that particular patient was. That's an anecdote, but so there's reason to believe that it may be helpful in addiction.
Thank you.
Thank you very much. Over here.
If I may ask 2 questions. First one would be for Dr. Palmer. So my name is Bobby Glahn, and I work in a way that I teach patients a ketogenic diet for diabetes and obesity. And I have a sister who suffered a traumatic brain injury, and it completely changed her. And for many years, we didn't have the person we used to know. And I was just wondering, in the type of work you do, if you have heard of or seen personally, she actually asked her medical professionals about using a keto diet because I recommended it to her to check into it or look into it. And like many people have experienced, she was shut down very quickly because she is a bit of a rebel in her nature. That part of her was still there. She did it anyway. And similar to the story of skipping and jumping and just a changed person, we got our sister back. And it's been life-changing for her. I was just wondering if you've seen any research on that having that kind of information can sometimes plant seeds in other medical providers and at least get them to be supportive of something that really works for her and other people in her traumatic brain injury group.
So the bottom line is, yes, there is research going on in that area. The NFL in particular is interested in this subject. There are some NFL players championing ketogenic diet and other metabolic strategies after traumatic brain injury. The military is interested in this. We have animal studies showing a benefit, but the human trials, we don't have a large randomized controlled human trial at this point. But I know that some people are interested in trying to make that happen. Getting funding for ketogenic diet research, especially rigorous trials with large sample sizes, is difficult.
Thank you. And if I may ask another question to Dr. Johnson. Way back when I first started school, I'm a registered nurse, we called vasopressin the antidiuretic hormone, or ADH. And with your explanation, and I'm going to go back and listen to your lecture like 5 more times to make sure I understood it all. But it involved salt and it involved water, and the vasopressin all kind of interrelated. I was just wondering, with people being in ketosis, they oftentimes need some sodium added. How do you find that sweet spot so that you're diuresing the right amount and you're getting the right amount of salt? Do you have any guidance or information on that?
Yeah, so a simple test is to just look at the color of your urine. And if the urine is concentrated, it will be dark yellow. And and then the more water you drink, it can go all the way to being completely clear. And what the evidence is that if it's just slightly tinged yellow, that's the osmolality of the urine that correlates with being well hydrated. So you can water intoxicate. There are people who you can drink too much water and actually drop your serum sodium and have a bad outcome.
Right.
So you don't want to overdrink. And the classic situations where people overdrink is like in marathon running, where you can drink and drop your serum sodium, and it can be life-threatening. And so when you're running a marathon or doing endurance running, they tell you to just drink to thirst. And likewise, if you've just had surgery, the first 48 hours, you're very prone to become water intoxicated with high water intake. And then, if you have things like heart failure or so forth, you need to talk to your doctor. But in general, hydrating like this, what I told you, 8 glasses a day is a good target. And you look at your urine to try to keep that urine just slightly tinged. So not completely translucent or clear, and not dark yellow.
So a question came up after your presentation. You said glasses. Is there a quantification on that? Some of us, we're down to 1 drink a day.
8 ounce glasses or cups, 8 ounce or 6 12-ounce glasses.
Yep.
Thank you. There's a question on the app, which I'm going to split up. Amy, do statins, antidepressants, or other drugs affect thyroid labs? And then there's another part of this that I'll direct toward Chris, but I think I already know the answer. But
I'm honestly not sure. I'm more concerned with how the thyroid condition affects the need for a statin or an antidepressant. I mean, the medical providers might know more about that. But there was a second part?
Yeah, the second part was, let's assume it does. Should patients stop meds before being tested? And I think the answer is no, not without medical supervision. And again, that's, so I think we've answered that question, unless you have anything to contribute, Chris.
No, but I mean, so Tro had mentioned some other we do know that some medications can affect thyroid status, and just as a point of interest maybe, if you go for a thyroid test, if you happen to be supplementing with biotin, you want to discontinue biotin supplements a couple of days before a thyroid test.
Okay.
That I do know. And just one thing to tail end on Dr. Johnson's thing about the urine, just as a nutritionist, if you are taking B vitamins or a B complex, your urine might be fluorescent yellow. So the hydration thing you might have to take that into account if you're looking at that, if you happen to be taking a B complex.
So I'll just say, with psychiatric medications, including antidepressants, please do not stop them on your own abruptly. You might get lucky and it might not be problematic, but I have seen people become psychotic, manic, suicidal, dead, arrested, all sorts of bad things. So just be warned. Even though I very much am passionate about getting people off meds, I am not saying people should take their meds and keep taking them and just follow doctor's orders and that is the way, but I am saying it is dangerous to stop them abruptly. So just please don't do that.
Thank you. Question over here.
Good evening. My name is Ellis Vivian, and I'm a family physician from New South Wales, Australia. My question to the panel is, now that we find TSH normal and go digging with a T3 and a T4 and a reverse T3 and find reverse T3 predominant, how to manage that?
Yeah.
If the TSH comes normal and we order the next panel, which is a T4, T3 and a reverse T3, and if the reverse T3,
Sorry, what's normal? TSH?
TSH.
TSH was,
I mean, some
Oh.
people think 0.4 is normal, some people think 0.5 is normal, some people think 5 is normal.
the labs give a range from 0.4 to 0.5 as the lower limit and 4 as the higher limit. So if that is within the parameters, but then as Dr. Amy Gerber said, we go digging in, find out that TSH is not the actual marker, but find T3, T4 and reverse T3. And if reverse T3 is predominant, how to deal with this clinical scenario?
But are there symptoms present?
Yes.
Okay.
So, yeah, great question. What I've seen is that you would give T3 because you don't want to give T4 in that case because there's a risk of the T4 being converted into more reverse T3. You could give something like Armour or a natural desiccated, but that's also predominantly T4, which could again be preferentially converted to the reverse. I think, again, I'm not a doctor, but in the research that I've seen, you would just give straight T3, liothyronine or cytomel.
Thank you.
Dr. Tro?
Not my area of expertise, but I don't think there's any harm to very microdose T3 if you wanted to experiment and the patient's open to it. I don't particularly do that, but I know I've seen it done.
As a psychiatrist, we use T3 all the time for decades since the 1960s. So this is, as Amy mentioned, it's an evidence-based augmentation strategy for bipolar disorder, chronic depression, lots of others. And as a rule of thumb, we just wing it. We're not really all that fancy. We start with like 25 micrograms of cytomel, see what happens. If somebody says I'm overstimulated, you decrease the dose. If somebody says it's not doing much, maybe it's doing a little, you increase the dose. You might check labs. I mean, in my book, I describe a patient who was clearly, had suppression of TSH. So by all definitions was hyperthyroid, but that is what it took to put his chronic bipolar disorder into remission. I actually got a consultation with the dean of Harvard Medical School, who was an endocrinologist by training. And he consulted to this patient and said, this is a very reasonable treatment given this man's suffering, like 30 years of suffering. And just watch out for osteoporosis, warn him of atrial fibrillation, make sure he understands there are risks with this treatment. My patient never had any of those risks. After like 10 years, was able to go down to a normal TSH range and has been fine since. So,
Quick question. I've heard several on the panel mention books. Are any of those for sale here on the premises during this event?
mine is not.
No? Amy, you've got...
I had a few copies. They might already be gone, but
darn.
if they're here, look at the Adapt Your Life table.
Okay.
They might already be gone. I don't know.
I missed it. Oh, there's...
We're not selling it here, but you can get it through the Amazon.
Amazon.
Yeah, so all books available through Amazon. Over here, please.
Hi, my name's Christine. I'm a family nurse practitioner in rural Missouri, and we have collaborative physicians in Missouri because we're a restricted state. My collaborative physician is Dr. Bradford Garner. I think he might be listening right now. But where we work, it's rural. We have people who do come to see us specifically for the health optimization, but we also have people who come in off their dairy farm and don't know what they're walking into when we talk to them about changing their way of eating. I've found that it's very difficult to open people's minds to looking to these therapeutic nutrition interventions. And I guess my question is kind of along the informed consent and ethics, sometimes I have to pull out, I have to listen to my audience and hear stories of infertility, erectile dysfunction, women who have never experienced an orgasm, crippling anxiety, and sometimes I have to kind of use those things to sell them the nutritional therapeutic intervention. I've asked my collaborative physician about it before, if that's me being manipulative, and I was just kind of curious if you all think that, in your experience, if using these types of motivational interviewing is ethical? Sorry, Dad.
You listed anxiety, which is amendable to lifestyle interventions, including exercise, diet, counseling, etc. You listed erectile dysfunction, which can be a little bit trickier if it's, I'll let the mental health people talk about that, but if it's vascular or, there may be some organic issues there. So, but there's been some data that lifestyle interventions, I think there's studies on walnuts and pistachios you could dig up if you really needed to support your claim. So I mean, there's data to substantiate some of the claims you're making. I think just as long as you're familiar, it's no longer unethical. I'd find it ethical.
Okay. Some of the thyroid stuff, people don't understand how that optimizing those levels can help with sexual performance as well, I think.
So one thing I would clarify is the way you described it, and maybe you're doing something different, but the way you described it to me, that is not motivational interviewing.
Okay.
Motivational interviewing is asking the patient, why are you here? What can I do for you?
Uh-huh.
They have to come up with the problem.
Okay.
It's not your job. That's actually anti-motivational interviewing, to tell them, you're overweight. Do you know what that could do to you?
Yeah, I don't
Do
do
you know
that.
what your insulin resistance could do to you long term?
Mm-hmm.
That is the medical model, actually, of shaming and hoping that we can shame them or scare them enough to do something. Mm-hmm. Whatever works, there's no law against the medical model of shame and scare. If that actually is effective, that's great.
I do not do that,
The
by the way.
the evidence, unfortunately, is that shaming and scaring often don't work for people, and they can backfire. They can make people feel worse about themselves, more hopeless, go home and binge eat, or whatever. And so motivational interviewing is really, you really have to work hard at it, because you really have to say, take a deep breath. I'm not going to tell this person everything that I know in my head. I'm just going to try to meet them where they're at and see if they can identify any problem at all. Uh-huh. You can occasionally ask them, can I share some information with you that I think might be relevant to what we're talking about? If the patient says no, you can't share it. Okay. That's motivational interviewing. So motivational interviewing is respecting the patient, letting them guide their own treatment. As soon as they say they have a problem, it doesn't matter what it is. I'm not sleeping well. My spouse is bothering me, and I'm stressed lately, and I'm coming to you for help. You can then say, can I share some information with you? They're probably going to say, yeah. Did you know that diet can actually play a role in your stress levels? Mm-hmm. Most people don't know that. And then you can start to, if you get some buy-in, if they quickly shut you down, that's not the road they want to go down today. But if they're open and curious, you can start to get there. But it's really about empowering the patient to make their own decisions. You want them to leave the office feeling like it was all their idea.
Yeah.
Not that you told them what to do, but that you want them to leave like, wow, she really helped me figure out what I can do to get myself better. Because now they're invested in the treatment. Now they feel smart. Mm-hmm. They feel like they can solve problems. Those are the mindsets they need to have in order to do the treatment.
Right.
If they feel like somebody needs to micromanage me and tell me what to do every day, they're not going to probably do the treatment very effectively.
Thank you.
Thank you.
For for Dr. Tro. And forgive me, I'm not familiar with the patient population that you serve, so assuming that you are serving patients who are not metabolically ill, as well as those that are you seeing differences in depression and anxiety between those two populations?
Can you repeat? So between metabolically well and unwell people?
Yes, in your practice.
I mean, the 99% of the people coming to our clinic, so we do PHQ-9s, Yale Food Addiction Scales, binge eating scores. You know, there's a 70% rate of adverse childhood events, 99% rate of food addiction symptoms, binge eating symptoms. We're dealing with a, metabolic, like the population is 7% free of metabolic syndrome. Our population is 0% free.
So that would be about the
syndrome.
U.S. population, wouldn't it?
Yeah, so we are running a study right now at Stanford with the great Dr. Shabani Sethi, who runs their metabolic psychiatry clinic, and we are looking at the baseline nutritional and metabolic labs and seeing what association they have in combination and separate from sort of the responses on these surveys. So we're trying to get that data into the literature, but as Dr. Palmer mentioned, nobody wants to fund anything.
Mm-hmm. And Dr. Palmer, from your presentation, your experience, is there anything you'd like to say to?
Mental health is metabolic health. They are inseparable.
Thank you. Thank you very much. Question over here, please.
So I'm Elizabeth Yurth, sorry about my hoarse voice, from Boulder Longevity Institute. I have a cellular medicine practice, so we work very pathway-oriented. And so I just want to make a couple of comments. I think that we're a little early in our understanding of the GLP-1 agonists. We use, because I use a lot of peptides in my practice, we use GLP-1 agonists a lot. And I know there's a frank hatred of the pharmaceutical companies. I understand that. There's other ways to get them. But the GLP-1 agonists, and I think, for instance, Dr. Clark, when you look at, I have a daughter, I have 5 kids, one of who is anxiety, depression, eating disorder, horrible. I can preach to her all day how to eat low carb. She's in college, she just doesn't do it. If I put her on a GLP-1 agonist, she's a different human being. So I think that you can utilize, at least early in the stage of things in these practices with mental health disorders, a GLP-1 agonist. Maybe that's a cheater's way around, but it does help quite a bit. We've now proven at least 4 different GLP-1 disorders in people who have depression, anxiety, and it's why they're in stage 3 trials for Alzheimer's. So we're using the GLP-1 agonists in cardiac disorders and liver disorders and brain disorders. So we're finding the GLP-1 receptor very, very prominent in a lot of these disorders. Thank you so much for bringing that. I'm so tired of people ignoring the metabolic health that's involved in depression and anxiety, but I know that they've found now at least 4 SNPs that are associated with depression and anxiety disorders that are all GLP-1. So I think some of those people are going to do okay on a ketogenic diet because it does, at least in the long term, raise GLP-1. That's probably one of the ways it works, but not in everybody. So I think we can't close the door to that the pharmaceuticals can extremely benefit people in this realm, especially early on when you're trying to get them to kind of actually start following some of the practices you want. So any comments on that?
I mean, in the bottom line nutshell is I am not anti-medication at all. If people benefit from medications, I'm all for it. And if they are a quick, easy fix, I'm all for it. The patients I see have been trying meds for decades.
But have they tried the GLP-1 agonists?
They're not working. Some of them have, yeah. So I'm all for new magic bullets. I mean, I hope that becomes the new magic bullet. I have every reason to be skeptical because I'm old enough in medical practice to have heard about the revolutionary new antidepressant that's coming out that's going to save the world, the revolutionary new antipsychotic, the revolutionary new this, the revolutionary new that. We've had weight loss revolutions all along, fen-phen and stimulants in the 1950s and 60s, and we've always had revolutionary new things that pharmaceutical companies are invested in selling that message. This is the revolutionary new saving, this is going to save the human race. Maybe they'll work out. Maybe this will be the one of the million times that it works out, but I'm not
I think
going
that's where you
to
have to
hold
have
my
an
breath.
understanding of pathway mechanisms.
Thank
Now,
you. We've got 10 minutes left.
So we have.
And I encourage you to have the conversation with people afterwards. Tro, you have a...
Yeah, can I take the GLP? So we've systematically used GLPs, okay? Maybe 5-10% or less of our patient population. We are at the point now where we are seeing, because these aren't new, they're just new for, people who are reading Newsweek, right? I mean, it's been in use for
they're
obesity.
new and they're used for brain disorders and things like that.
Yeah, so I can tell you from the standpoint of binge eating, it has been immensely helpful. People who struggle with binge eating report that for 6 to 9 months they have a normal relationship to food. I'll give you quotes. This is what normal feels like. Whatever keto did, this gave me more. I've had doctors come to me that I've put on them, who've specifically requested them. We have some people who, I can tell you, that, between life stress and depression and anxiety, they can't, depression and anxiety, and I'll let the experts talk about this, it's like a full-time job. Imagine trying to implement a lifestyle with 2 full-time jobs, anxiety and depression, right? You have 2 full-time jobs, plus a real full-time job, maybe you're a parent. So it's been immensely helpful. We're at the point now in the life cycle of this product where we are seeing all of the failures. So it is not a miracle. It's definitely not a miracle. And I'm going to tell you right now, we are already seeing the adverse events, the people failing. It's like the sleeve, it's like the balloon, it's like the, at least from the weight loss perspective. We see people even in diabetes becoming resistant to them. So it's a tool, it's in the toolbox. I'm going to tell everybody it's not a miracle.
Thank you. Over here.
Hi, everybody. Thanks for your presentations. My name's Amelia. I'm from Seattle. I'm a personal trainer. And this is a personal question for one of my clients. She had full resection of her thyroid a couple years ago and is on 150 milligrams of Synthroid. And her doctor will not change anything about that prescription, even though she's miserable. She can't lose weight. She works out 5 days a week. She's cut out a bunch of common allergens. And I was just curious, Dr. Berger, if you have any insight on that.
Find a new doctor.
Yeah, I keep telling her that.
Yeah, so just so nobody sues me, to clarify, I'm not a doctor.
Right.
So there's a couple of options. What state is this in?
Washington.
Okay, so Washington State, she can order her own labs. So she could go get herself a comprehensive thyroid panel. You can see me after to find out how to do that. Then the issue is once she has the labs back, we have to find a new doctor for her to work with. But so she's not beholden to that doctor. No offense to your doctors out there, but because we have so many great ones here, right? But a doctor is providing a service that you pay them for, just like a plumber, just like a carpenter. If you're not satisfied with the service you're receiving, fire them and go hire someone else. If she's not able to because of health insurance or whatever, there are a lot of doctors and nurse practitioners who work remotely who are licensed in various states. So she could even potentially work with someone outside of Washington State who can prescribe her the medication that she may need, the proper medicine, and something else I was going to say. That's it, but she is not powerless. Right. She needs to reclaim her own authority in this. She is not just a helpless victim of what a doctor is telling her or not telling her.
Right.
Thank you. We're supposed to end in 5 minutes. I'm going to give preference to people at the microphones.
Just one last thing for the person walking away. It's actually an indication, one of the indications, like clear indications for combined therapy, is actually full resection. If so, it's just bad medicine. I'm not telling them what to do, but get a new doctor is a good idea.
Yeah. Over here, please.
Graham Phillips from London. I'm a community pharmacist, but don't shout at me because I'm the pharmacist that gave up drugs. My question is to everyone. Is ultra-processed food the root of all evil?
Yes.
Yeah.
I'm going to say no.
Yeah, as a single cause, it's hard to identify one, so I'm going to go with it can be for some people, but it's not for all people.
I'm going to quote a young woman who is speaking sometime this weekend, Siobhan Huggins. I don't know if you're in this room, but I cite this every time this question comes up. Siobhan said at a conference years ago, "I don't care how processed a food is, I care about the metabolic effects." So for example, stupid example, but something like Crystal Light, it's an artificial sugar-free flavored drink powder, for those of you outside the US, that is highly, highly ultra-processed. But if you have type 2 diabetes and you weigh 300 pounds, for the love of God, please drink Crystal Light instead of a six-pack of Mountain Dew. Is Crystal Light a health food? Maybe not, but ultra-processed food may have a role in reversing some of these conditions if they're very, very low in carbohydrate. And that's maybe very controversial to say, but I don't think that these foods are necessarily poison. I think we have to look at the metabolic effects.
Thank you. Over here, please.
Hi, my name is Nancy Hempel. I'm a mental health counselor in post-secondary. I'm from Canada. A question about the keto diet for mental health to Dr. Palmer, I think. When you were beginning your talk, you paralleled it to the epilepsy treatment and that kind of thing. So I'm wondering, does the keto have to be that true keto that we often associate with epilepsy treatment?
Obviously, it depends on the patient, and you're just looking for a clinical benefit, and there's no one-size-fits-all diet to get a clinical benefit in all human beings. So just like medications need to be tapered and adjusted and different doses for different patients, and maybe even different therapeutic classes for different patients, same with diet. When I'm using it as a metabolic treatment in patients, I tend to see serious mental illness treatment resistant. For patients with mild depression and anxiety, I'm hearing from people all over the world, they just lower their carbohydrate content and that can be miraculous for them. So just lower your carbs. You don't even have to be keto. Just lower your carbs. Get rid of the junk food. Get rid of the processed food. Get rid of something. And for some people, that can be enough. I just talked with Tom Bilyeu, I'm not disclosing anything because he said it right on the podcast, so you're all going to hear it. But he was talking about how he had chronic anxiety and panic attacks, and he got rid of a diet soda that he was drinking regularly. Got rid of that, and 70% of his symptoms were gone. When I use the treatment, though, for serious mental disorders, schizophrenia, bipolar disorder, chronic unrelenting depression, I have to use it like an epilepsy treatment. So I'm looking for blood ketones greater than 1.5. As a rule of thumb, when those patients achieve blood ketones of 0.6, even though the weight loss people will say they're in ketosis, and some people will even say ketosis is like pregnancy. You're either there or not. I say, based on my clinical experience, well, that doesn't seem true. Some people need to be really pregnant with ketones because really pregnant with ketones produces a powerful antipsychotic effect for them. Whereas, and I have patients who are doing spectacularly well, complete remission of symptoms with ketones between 2 and 3.5. When they go down to 0.9, hallucinations are back. So it needs to be customized to the patient. Obviously, if that patient is asymptomatic on 0.9, I'm going to say, great, go for that. But the ketones do seem to matter.
And at that
Thank you.
rate, can somebody be in ketosis in the morning and then maybe not the next day and then back in, like that kind of thing?
So ketone levels can vary depending on stress levels and sleep and the foods they're eating and everything else, but I do not recommend that patients go off of the diet. So I specifically am advising them do not cheat with carbohydrates because we're trying to get an epilepsy effect. And we have decades of clinical research with seizures. There's no cheating. There's no cheat day. There's no cheat weekend. there isn't. Your brain needs this diet to heal itself. And so I'm using it in a similar way in patients with serious mental disorders.
Don't cheat yourself. One last question over here, please.
Hi, I'm Jody. I'm a nurse practitioner in Lincoln, Nebraska, and I work in a behavioral health clinic. So this question is primarily for Dr. Palmer, but we do addiction medicine as well as other mental health, and we use a lot of buprenorphine, Suboxone, those types of things to help get people off of the opioids and the other things that they're using. So my question to you is, along with if I can get some of them to buy into using the low-carb keto to help with some of the symptom management as well as the mental health piece, is there anything else you would recommend to help detox them or to get them off of the opioids and stuff, such as like the NAD?
It's a great question, and we really don't have good clinical data. One of my patients who appeared with me, some of you might know her because she appeared with me at Metabolic Health Summit 2 years ago, chronic schizoaffective disorder. She just got off her Suboxone completely. It took a while. So it's going to be the same strategies that you're going to use anyway. Very, very slow, gradual tapers, a lot of behavioral interventions. What are your triggers? How are your stress levels? How's your sleep? If they're using exercise and other things as part of their treatment approach to just lifestyle interventions, you want to keep those up. You want to taper very, very gradually. But I think you and I both know somebody taking Suboxone is a lot better than going out and shooting up with heroin.
Absolutely. Okay, thank you.
Thank you for the presentations. Thank you for the interaction, and we'll see you around.